Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
My fellow CardioNerds, we are incredibly excited for today's Pulse Check to learn more about cardiac amyloidosis directly from Dr. Witteles from Stanford. This episode is the fourth and final part of our immersive journey into the jungle of beta-pleated sheets in the heart. Please be sure to check out parts 1 through 3 to prepare for today's discussion. But first, I want to tell you how honored I am to be joined by Dr. Ashley Bock.
Thanks, Amit. I'm happy to be here.
Now, friends, Ashley is a genuine cardio nerd. After earning her medical degree at the University of Colorado, she completed her internal medicine residency training at Duke University. From there, she came to the Cleveland Clinic for general cardiology fellowship and stayed on for advanced heart failure training. She was not only a star fellow, she was also my chief fellow. And as a chief, she not only made our program better, but also did something very special for me personally. Now, actually, I don't think you remember this, but when I was finishing up my residency, you emailed my incoming class of my co-fellows asking us for our schedule requests. And my very first request for you was to have extra time off in the beginning of fellowship. As awkward as that request is, it was because my wife and I were expecting our first child. And you not only managed to give me the regular 2 weeks off, but you paired me up on a month-long heart failure rotation that typically only requires one fellow, and you paired me out with Karthik. And so it just gave me a lot of flexibility, and along came Dhruv in the first week of fellowship, which was terrible timing, but that extra time and flexibility just was so special, and I think completely timeless for us. And so, I just want to thank you for starting off my fellowship and parenthood on such a positive note.
You're very welcome. I appreciate that story. I feel like that was a very obviously important time in your life, and I knew that was going to be a big deal. And I think, in medicine, we try to make sure that we're also not only helping each other through training and getting through the rigor of clinical duties and things like that, but also with these life events that come up. So.
Well, we very much appreciated it. And, you were just such an effective chief for our fellowship. I'm wondering, what did you take away from that experience?
So, I felt very honored when my class selected me to be their chief fellow. I think it's interesting the way that the Cleveland Clinics does this and has the class actually select who they want to be their representative, because to me, to have a group of 14 people that entrusted those responsibilities in me and trusted me with even kind of some intimate details that come up in their lives that are part of being chief, that are outside, like I mentioned before, of medicine, was very special. So running the general cardiology fellowship can be quite a task at times, just because with 45 fellows, you're trying to balance all of their lives and also professionally what they want from the program and what they want to get out of the program, while making sure that you also are ensuring all the clinical duties are covered. So I think just learning how to balance all of that and to be fair was a huge thing. And for me, I tried to stress that part more than anything, because I never wanted to have people feel like they weren't an integral part of the decision-making process and that they weren't in charge of their own career and their own experience. So I think trying to balance out what you had to do with what people wanted to do was a big part of it.
I'm sure.
And how to make this fellowship the best it could be for every individual to move their career forward. That was a big part of that for me. And then one of the perks, I think, of being a chief fellow was that I got to meet a lot of other folks from all over the country who would come to give grand rounds, Dr. Witteles actually being one of them.
That's very cool.
But that was a wonderful experience too, because then you get to interact with folks on more of a personal level, have dinner in a small group with other co-fellows. And I always tried to get as many other co-fellows as I could at those dinners, just because I think it's important to develop this network, with folks and have these open dialogues about cardiology and medicine and patient care, and trying to move the field forward collectively. And a lot of these dinners, those are the things we would talk about, because I think everybody has a different spin on how they would treat a condition and things they do differently at other programs. And that was just a really special part of it as well.
Oh, I'm sure. And I wonder, do you think The time that you spent here as a chief, did it at all make you interested in having a leadership role later on in your career?
Absolutely. I mean, I think if anything, it furthered that kind of passion and desire in me to be in those roles. I think being part of something that you kind of help the fellowship grow and become better and hopefully leave it better than you started with. I think that's a lesson that carries on at any time in your career. And it's definitely something I'd like moving forward to do.
Well, that's awesome. Well, I, for one, am very thankful that you were my chief, and I'm so glad that you were able to join us today for this recording. For the lawyers, this podcast is not meant to be used for medical advice. The views expressed here do not necessarily reflect the opinions or policies of our employers. The goal is simply to enjoy learning more about cardiology directly from expert CardioNerds. Now, let's see if we can get Dr. Witteles on the phone. Hi, Dr. Witteles. Welcome to the CardioNerds podcast.
Happy to be here.
Dr. Witteles, I'm here with Dr. Ashley Bock. She is now an advanced heart failure fellow here at the Cleveland Clinic, and I believe you met her last year during your visit to Cleveland when she was our chief fellow for the General Fellowship.
I sure did. Hi, Ashley.
Hi. So we're so glad you're joining us today on CardioNerds. For our listeners, Dr. Witteles requires no introduction, but Amit gave me a script, so here we go. So Dr. Witteles attended the University of Chicago Pritzker School of Medicine. He left the Chicago winter behind for sunny Palo Alto, California, to complete both internal medicine and cardiology training at Stanford University, where he has also served both as chief resident and chief fellow. He is highly regarded in both the heart failure and medical education communities. He is co-director of both the Stanford Amyloid Center and the Sarcoidosis Program, as well as the program director of the Stanford Internal Medicine Residency Program. He is also an associate editor for JACC, Cardio-Oncology. I would love to share his long list of accolades, but I'm sure that Dr. Witteles has to get back to recruiting a new class of bright Stanford interns.
Dr. Witteles, we are all very excited to learn from you. And for those who don't know, I met you when you and the Stanford residency leadership were visiting us at Hopkins last academic year. And I had the privilege of hosting you on my team's bedside rounds. And I remember very clearly that the sharp young student doctor was presenting a complicated case of a patient with numerous metabolic derangements with likely, unfortunately, a new diagnosis of advanced lung cancer. And you, on the spur of the moment, gave us these beautiful pearls about differentiating PTH-dependent versus PTH-independent causes of hypercalcemia. I really enjoyed learning from you then, and I'm super excited to learn more from you today.
That was a really fun visit. Thanks to you and the whole Hopkins team for inviting us. Then we do an exchange program with another big academic residency program each year, and it's one of the highlights of the year. So thanks for your hospitality.
Oh, it was such a pleasure for all of us. So let's get right to it. Our first question for you is, so the stage is a patient where we have a high index of suspicion for cardiac amyloidosis, and based on the gammopathy panel, we're concerned at this point for AL cardiac amyloid. In this kind of situation, what is the sequence of tissue biopsies you generally pursue? Is it the bone marrow? Do you go to the fat pad, or do you go straight to the endomyocardial biopsy?
So you can reasonably justify any of those, but with the caveat that if you don't go straight to the cardiac biopsy, you need to very, very quickly go there if the other testing is indeterminate. So fat pad biopsies have the advantage of being the least invasive test. In fact, it can just be done in the office. The problem is that, the yield isn't great. You'll read that it's upwards of 80% in AL amyloidosis, and probably in very specialized hands and with very good pathologists who are very experienced with amyloid, that's the case. But it's not reliable at that. And in our experience, the false negative rate is quite a bit higher than that. The other problem is that, remember that the key is not just making a diagnosis of amyloidosis, but subtyping it. And sometimes there's enough tissue for the pathologist to say that, yes, there are Congo red positive deposits, but not enough tissue to subtype. And here's the thing. For AL amyloidosis or AL cardiac amyloidosis, I would think of it as a near emergency to get to make the diagnosis. That disease can progress extremely quickly. And days and weeks can matter in terms of the outcomes of the patient. So if you have the capability at your institution of endomyocardial biopsy and skilled hands, generally I would recommend going straight to that. The nice thing about amyloidosis is that when you biopsy the clinically involved organs, so in the context of our discussion, the heart, you essentially have a 100% sensitivity and specificity, which is very different from other infiltrative diseases like sarcoidosis. From my perspective, going to where the money is to get the correct and accurate diagnosis quickly so the patient can start therapy is the most important for a disease that can really gallop along quite quickly.
That's perfect. So I guess we just have to get to the heart of the matter, so to speak.
Indeed. And I should say just a quick word about the bone marrow biopsy. So the patient will end up getting a bone marrow biopsy because in the scenario provided, you've already proven that they have a monoclonal gammopathy of some sort. However, what you're trying to find is not that they have abnormal plasma cells. You pretty much know that already. What you're really trying to find is, on that biopsy, is are there amyloid deposits, which actually most of the time you won't find in the bone marrow. But if you do, again, there has to be enough to subtype. And B, secondarily, do they meet qualifications for having myeloma? But even there, that's based on the percentage of plasma cells in the bone marrow, and usually is not the rate-limiting step to deciding whether or not a patient has a treatment indication or not. So you're going to do the bone marrow biopsy, but believe it or not, for this hematologic malignancy, it is not the most important biopsy that you're doing.
That's very helpful.
And you kind of alluded to this already, but oftentimes we don't come up with a diagnosis of cardiac amyloid until the pathology is well established. Do you think there is a screening strategy that we could use that would be able to diagnose this more early on in its course?
Yeah. Well, I think here we have to very much differentiate between transthyretin amyloid and AL amyloid. And I know you're speaking with someone else primarily about transthyretin amyloid, but when we're talking diagnostically, we have to think about both. So transthyretin amyloid is, first off, not rare. In fact, in the patient population, it's downright common. B, progresses at a relatively slow rate. C, has a ability to be non-invasively diagnosed fairly inexpensively and accurately as long as you follow the right sequence. And D, can now be effectively treated, not cured, but effectively treated. So for transthyretin amyloidosis, I actually do think that, and we published on this last year, that a screening policy in the right patient population makes sense, which we put forth, a task force, the privilege of co-leading, put forth that anybody who's above a certain age, 65 in men, 70 in women, who have wall thickness above 14 millimeters in their ventricular septum, or have any red flag criteria like carpal tunnel, we would suggest screening. Now, that's for transthyretin amyloid. For AL amyloid, it is a considerably less common disease than transthyretin amyloid. Certainly, there's no widespread screening program of any population demographics that would make sense. I would say anybody with a known monoclonal gammopathy, whether it's MGUS, myeloma, Waldenstrom's, it is sensible to do some very basic screening, such as one could check for basic cardio biomarkers, check an echo, make sure there's no evidence that they actually have amyloid deposition. I'm hoping the day will come fairly soon where there's reliable enough imaging that one could do probably nuclear-based imaging to see if there's any uptake. But we're not quite at that point yet. So no, I wouldn't generally recommend screening for AL amyloid, but you do need to have a high index of suspicion when the right clinical clues are there. And then once you have that suspicion, to quickly move towards getting a diagnosis.
That's very helpful. So it sounds like the justification for screening early for TTR amyloid make a lot of sense because it is a lot more common than was once believed, and we have more effective treatment strategies than we once had.
Right. In fact, I might say we have treatment options, which we didn't used to have. And, so if you think about what makes a good screening test, it has to have a high enough prevalence in the patient population whom you're screening. You have to have an accurate and preferably non-invasive testing modality, and you have to have an effective treatment if you make the diagnosis. So as long as you're picking the right patient population, it checks all those boxes for transthyretin amyloid, but in a way that it doesn't for AL.
Mm-hmm. And in general, how do you think the medical management of patients with a diagnosis of cardiac amyloid, whether it be AL or TTR, is different from the treatment in our routine heart failure patients, either HFpEF or those with reduced ejection fraction as well?
Sure. So I like to think, and this is how I describe it to patients, that when they have a diagnosis of systemic amyloidosis, we want to think about their treatment on two parallel paths. Path one is what can we do to treat the underlying cause of their amyloidosis. So for transthyretin, of course, right now it's tafamidis. For people with cardiac involvement, hopefully more therapies to come. For AL amyloidosis, it is with effective chemo or an immunotherapy, as I imagine we'll be getting to in a few minutes. And what I'd emphasize is that is importance 1, 2, and 3 in treating the disease, far more important than anything else. Now, part two, also still important, however, is to treat the manifestations of the organ dysfunction that has occurred from amyloid infiltration. So from the cardiac standpoint, that's mainly managing their clinical heart failure and their arrhythmias. So what that mainly involves in patients with cardiac amyloidosis is volume management, first and foremost. They are particularly AL patients, tend to be quite volume overloaded and generally quite under-diuresed. And that's because patients with AL amyloidosis will usually have at least some degree of autonomic dysfunction. Mm-hmm. They have relatively smaller cavities, often some chronotropic incompetence, and they will, if they have renal involvement, will often be quite hypoalbuminemic and have low circulating volume. And so for all those reasons, they tend to run hypotensive, and they can easily have renal dysfunction either from hypoperfusion or from direct renal involvement. And so the mistake is to just let them drown in fluid, and that's what often happens. So first and foremost is getting proper volume management with salt restriction and diuretics. If they have lots of edema, compression stockings can be of help. And if they're really running into problems with significant hypotension, particularly postural hypotension, this is a group in whom midodrine can be helpful. What is generally not helpful are the traditional neurohormonal blockading agents that we think about, certainly for heart failure with reduced ejection fraction, namely beta blockers and renin-angiotensin-aldosterone system blockers. And that's for a couple of reasons. First off, the reason why those classes of medicines are so useful for most patients with HFrEF is that the progression of that disease tends to be largely because of the neurohormonal upregulation, whereas the progression of the disease here is really first and foremost the progressive amyloid infiltration. Secondly is the hypotension that I just alluded to, particularly the postural hypotension, which both of those agents will worsen. Mm-hmm. And then third is from a rhythm standpoint, heart block is common in the disease, and as well as just overall sinus node dysfunction and chronotropic incompetence. And patients, because of having small cavities, will often be somewhat dependent on a higher heart rate. So generally, unless it's needed for control of rapid ventricular response from atrial arrhythmias, generally you want to avoid beta blockers, you want to avoid RAS inhibitors, and it's really about volume management and rhythm management. Happy to address the rhythm management now or later, whatever you prefer.
Sure, I'd love to hear it.
Sure. So really, I would divide those into the atrial arrhythmias, ventricular arrhythmias, and then pacemaker indications. So the easiest is the pacemaker indications. They, like anyone, if they have symptomatic bradycardia, a pacemaker is appropriate. And again, heart block is reasonably common, although even more so probably for transthyretin patients. From a atrial arrhythmia standpoint, certainly atrial fibrillation and flutter are common. We know, and there's both from clinical experience, and now there's some pretty good data to say that the rates of atrial thrombus are particularly high in patients with amyloid cardiomyopathy, likely because their atria are so diseased and the flows are so low. And so it's generally recommended that a transesophageal echocardiogram be performed before any cardioversion, regardless of whether the patient has been on adequate systemic anticoagulation beforehand. Often patients will poorly tolerate atrial arrhythmias. So if you can maintain sinus rhythm, it can often be helpful. But of course, we know there are patients who that's not going to be possible with, and ultimately they just need a rate control and anticoagulation strategy. Atrial fibrillation ablations are occasionally done, but certainly much less successful for this disease because, again, of the diffuse amyloid infiltration of the atria than for most other indications. From a ventricular arrhythmia standpoint, this is less clear how to handle. So the general thinking has traditionally been not to place defibrillators in patients with cardiac amyloidosis, but that really came from an era when the prognosis was truly dreadful in the disease, and placing a primary prevention defibrillator didn't make any sense because the life expectancy was not enough where that would make sense. In fact, often all you would be doing would be condemning your patients to having ICD shocks at the end of their life. That, of course, has thankfully changed as therapies have improved.
Right.
And we and others have published looking at, well, what are the rates of ventricular arrhythmias and how effective are defibrillators? Because that was one of the other myths, was that defibrillators are generally ineffective at resuscitating patients from ventricular arrhythmias. But again, that was from an era when they would put ICDs in patients with absolutely hearts completely full of amyloid, and it would either fail to convert them or they'd convert and be left in PEA. So that's clearly not the case now. If you put defibrillators in, they are the vast majority of the time, they will effectively convert the patient. So our policy, albeit this is not based on a high level of evidence, but our policy is that for patients with AL amyloidosis who are clearly at higher risks of ventricular arrhythmias leading to sudden death than patients with transthyretin amyloidosis, that as long as they have a life expectancy greater than a year, which is the large majority of them, we offer screening, typically with a Zio patch. And if we see any significant burden of NSVT, we offer them a defibrillator. Or, of course, if they have a high-risk sounding history, we will also offer them a defibrillator.
That makes a lot of sense. And moving along the same train of thought in terms of device therapy for cardiac amyloid patients, what are your thoughts about the effectiveness of CRT in these patients in the right setting?
Yeah, I mean, I guess the key is the last few words you said, in the right setting. The patients, from my experience, don't tend to benefit as much from a CRT with conduction disease as many other cardiomyopathy patients. And indeed, when you look at their ventricles, they don't tend to be nearly as desynchronous. That being said, if you have a patient with a wide left bundle, it's certainly worth a try. And if you're putting a device in and you expect that they're going to be chronically ventricularly paced, I think pretty much all of us would prefer CRT rather than RV pacing. But I would say most patients, most patients do not need CRT, but if they're going to be chronically paced or have a wide left bundle, sure.
Gotcha.
And just to follow up about atrial arrhythmias and strategies. So if you had a patient in clinic, for example, who presents with cardiac amyloid and has large dilated atria on echo, but really no history of arrhythmia, do you, like you had mentioned for ventricular arrhythmias, send them out home on a Zio patch and then anticoagulate based on evidence of atrial arrhythmia on monitoring, or does it depend on what you see on the echo findings, just because of such a large thrombus burden in the atrium that can develop and obviously then be an inciting event for stroke in these individuals?
Yeah, I have an extremely low threshold to anticoagulate in patients with cardiac amyloidosis for the reasons discussed. So if we ever capture them in atrial fibrillation, that would be a reason to, as far as I'm concerned, have lifelong anticoagulation in the absence of a strong contraindication. And again, we will generally, unless we're talking about somebody with a very poor life expectancy, we will generally do a Zio patch monitoring anyway to look also for ventricular arrhythmias. And again, if we catch really any bird, more than I guess a couple of beats of atrial fibrillation or flutter, we would generally recommend anticoagulation. The risk of thrombus is just so high in these patients.
And talking about the general medical management of these patients, are there any specific medications we should avoid for cardiac amyloidosis? We all learned in medical school that we shouldn't be using digoxin and calcium channel blockers.
Yeah, and that, at first, it is bizarre that that's one of the things that are taught in medical school, and yet it seems ubiquitous. It's a very specific thing. But like many things taught in medical school, it's not necessarily completely true. So the concern comes from the fact that many medicines bind to amyloid proteins, and including and certainly specifically calcium blockers and digoxin. And so, for example, there's concern that even if you have somebody at a typical therapeutic dose of oral digoxin, and maybe you even check a serum level and it's where it's within the range you'd like it, that they might actually still have dig toxicity where it counts in the heart because they're having local binding of digoxin. And so for years, it was sort of a complete contraindication you're never going to use. Now, I will say that most of us in the field are willing to use it at low doses, particularly in transthyretin amyloid, if it's really needed for rate control. As I was mentioning before, when you're trying to rate control, there's not great options here. We've talked about the downside of beta blockers. Calcium blockers have both similar downsides and this concern about, again, binding to amyloid fibrils. We just talked about digoxin. You're quickly running out of options. So I would say I think pretty much all of us who care for patients in this field have used digoxin occasionally. Again, I think probably a little bit more with TTR, but I wouldn't rule it out for AL either. But specifically and only for rate control of atrial arrhythmias, there's certainly not a role, as far as I'm concerned, for any of those medications in the absence of that.
Being an advanced heart failure fellow, I'd be remiss if I didn't ask you about the role for advanced strategies in these patients, specifically transplant or LVAD, palliative care, and your thoughts regarding that in folks who really have other limited options in terms of treatment.
Sure. Well, first I'll get on my soapbox and say that I hate the term advanced strategies. I actually don't think we should consider transplants and mechanical support advanced strategies for any form of heart failure. I think the better term would be salvage therapies, of something that you're happy to have but would rather not need to use. And the advanced strategy is being able to manage the patient where you don't need those things. But I will now get off my soapbox.
I do like that.
I like that term as well. Good. I think I'll start using it from now on, if you don't mind.
It was one of our residents here who actually went into palliative care, which I suppose makes sense, a few years ago, who on CCU rounds, that when I had gotten on my soapbox, had suggested the term. And I actually think it's perfect. And maybe it's the CardioNerds podcast that will start getting this popularized around the country. But
salvage therapies.
Yeah. One can only hope.
Yes.
Starting day.
Exactly. But anyhow, to answer your question directly, so let's separate them into mechanical circulatory support and transplant, because I think it's very different for this disease. For mechanical circulatory support, generally, these patients are very poor candidates, and there's a couple of reasons. Number one is that the problem is biventricular. It's every bit as much an RV problem as it is an LV problem. So putting an LVAD generally is not a great option. Now, again, never say never. Are there ever patients who do seem to get a real benefit out of it? Yes. I would say it tends to be done more for transthyretin than AL when it is done. And you at least then don't have the immunosuppression of the chemotherapy side of things. But generally a poor option for these patients. The other problem is, of course, they often have small cavities because of the wall infiltration. So all the problems that go with that with an LVAD. Okay, now, separately from transplant, so there had long been an idea that you do not transplant these patients because their outcomes are terrible. And that was from a time when the chemotherapy options were dreadful, as we'll probably get to in a moment. And they also did not pick patients well, so that they would pick patients who had multi-organ involvement of AL amyloidosis, replace their heart, and they would still be left with very dysfunctional kidneys, liver, GI tract, et cetera, and not surprisingly wouldn't do well. So I would say starting around the early to mid-2000s, a few places in the U.S. Started carefully selecting patients. And this was around the same time that the chemo options had significantly improved. And we and others have shown, like we just published our most recent experience on this, we and others have shown that as long as you pick your patients very carefully, and for the ones who have AL amyloid, give them effective chemoimmunotherapy to control their light chains, that they can do very well. And so in our recent cohort of over 30 patients who were transplanted over about a 10-year period, our survival among our amyloid patients has actually been slightly better than our overall transplant survival period.
Wow.
And we haven't lost one patient due to recurrence of amyloid in the new heart. So the key is you have to pick the patients very carefully. It has to be done at a center that has experience with this. And I would say particularly for AL amyloid, if it's going to be done, you really want it to be done at a center with experience, and you want to be very vigilant to controlling the light chains afterwards.
Wonderful. And I'm wondering, one thing that we run into is a specific strategy for supporting these patients while you're trying to get them to these salvage therapies. Because I think with folks with cardiac amyloid, that restrictive physiology is a little bit different than what we're used to treating in the kind of general shock patients that may have big dilated ventricles, and it may be, as you mentioned, more left-sided heart failure than biventricular dysfunction, and how you keep these folks stable trying to get to transplant to another strategy.
Yeah, so it's not easy. And there was a nice abstract that was shown a few years ago out of MGH where they looked at their experience and they looked at their waitlist mortality for their amyloid patients and all other patients. And like the all other patients seem to go on for years without getting transplants, which one could that's a topic for another day. But the AL patients, if they didn't get transplants, they all were dead within a couple of months. I mean, it was amazing. So it is a challenge because, again, it's mainly a disease of diastolic dysfunction, which we obviously don't have great options. We talked about the lack of utility of mechanical support for these patients. So, do they get any benefit out of inotropes? Yes. I mean, in terms of the short-term benefits, yes. Some of it, honestly, is probably getting their heart rate up. And some of it is that, yes, they probably do get a little bit of extra inotropy and lusitropy from them. But you're talking about inotropes we know aren't great, even intermediate-term solutions for heart failure patients in general, and even less so in amyloid. And obviously, the arrhythmia risk is very real. So the key, the real key is if they're heading towards transplant is trying to, of course, see if you can get them transplanted before they quite get that ill.
No, that makes a lot of sense, and certainly sounds like a difficult position when these patients come in shock. Now, as a leader in cardio-oncology, I have to ask, are there notable cardiovascular toxicities of amyloid treatments that cardiologists should be aware of, especially as we're co-managing these patients with our oncologists? And just for the audience, oncologists of 2020 certainly are better equipped with multiple strategies for amyloidosis, including hematopoietic stem cell transplant and numerous classes of agents, including steroids, notably dexamethasone, proteasome inhibitors like bortezomib and carfilzomib, immunomodulators like thalidomide, lenalidomide, pomalidomide, cytotoxic agents like cyclophosphamide, and a host of newer agents like daratumumab, which is an anti-CD38 monoclonal antibody against the cell surface protein. So when we think about co-managing all these patients on different agents, possibly multiple lines of therapies in the past, are there anything that you think cardiologists should at least be aware of?
Yes, I'm glad you asked. And if you don't mind, I'm going to broaden the question a tiny bit to just overview the hematologic therapy as a whole, recognizing the audience here are cardiologists, not hematologists. But I think the bottom line is if you are going to be co-managing these patients, you have to have some understanding of the treatments, what the options are, and what the goals are. So I'll just take a quick moment to highlight those things.
Sounds great.
So, and I would say, by the way, that getting to that point, that it's my firm belief that we need to, as a field, democratize transthyretin amyloid diagnosis and treatment and undemocratize AL amyloidosis diagnosis and treatment, meaning that transthyretin amyloidosis is common. The diagnosis is actually reasonably straightforward. And the treatments, at least as of 2020, is very simple. Right now, it's one approved treatment, which is a once-a-day pill without toxicities. AL amyloidosis is completely different. It involves multiple organs. The diagnosis can be tricky. Understanding light chains and all the different therapy options is definitely tricky. When to switch chemo or immunotherapy, when you should consider stem cell transplant, et cetera. So whereas I would love to see community cardiologists diagnosing and treating transthyretin amyloidosis, not feeling the need that every one of those patients ends up needing to be referred to a specialty center. I feel the opposite about AL amyloidosis, that those patients should all be offered an early consultation at a center of excellence for treating the disease. They may get all their chemotherapy and whatnot locally, of course, but it's really something where I think that patients benefit from at least a early consultation at a specialty center. Now, in terms of the hematologic treatments, so one thing that's a very important concept is that the goal is not to get a patient a specific kind of therapy. The goal is to control the light chains. And that may seem obvious, but I would say historically, and still I feel a lot of the time, it's not viewed that way. And what I mean by that is when the disease first was being treated, the chemotherapy, the traditional chemotherapy options were very limited and not very effective. It was essentially the alkylate or melphalan plus a steroid. And it just wasn't very effective. And so the idea was, well, gee, I wonder if there's a way to give them more chemotherapy. But the problem was that if you give them more of an alkylator, melphalan or Cytoxan, you would wipe out their bone marrow. And so, okay, we have a way to deal with that. We give them a higher dose of an alkylator, and then we rescue them with an auto stem cell transplant. Important to recognize. We're always talking about auto stem cell transplant with this disease, never allo. Allos are not done because they're considered too toxic in this disease. It's always auto transplant, meaning you're getting your own cells back. So there's no graft versus tumor effect. All you are achieving with an auto stem cell transplant is the ability to give a higher dose of a single kind of chemotherapy, namely an alkylator, than you could otherwise give. So it seemed to make sense. Hey, this will probably do better if we can give higher doses. So there was a host of data that was all observational that said people who got stem cell transplants did better. They lived longer. But of course, there was a huge built-in bias there, which is that there's a reason why some patients got stem cell transplants and others don't. And usually the ones who were getting the stem cell transplants were much less ill or better candidates for all the host of reasons that people can be better candidates than the ones who did not get stem cell transplants. So of course, what was needed was a randomized trial. Well, fortunately, there was one. So there is one and only one randomized trial that ever compared standard chemotherapy to stem cell transplant. It was done in France in the early to mid 2000s. The chemo that people were randomized to was the state-of-the-art chemo at the time, which sadly was just melphalan and steroid. And auto stem cell transplant was then what it is now. That hasn't really changed for the disease. So everybody's ready for the results to see that stem cell transplants is going to blow chemo out of the water. Well, guess what happens? There is a statistically significantly better survival in the standard chemo arm over the stem cell transplant arm. Now, the stem cell transplant advocates came back and said, well, hold on, it was a small study, 100 patients, it was done in France, a bunch of small centers, maybe they didn't really know what they were doing, the transplant-related mortality was too high, but thankfully, the authors had pre-built in a 6-month landmark analysis saying, let's look at survival also as a secondary endpoint of those patients who got their treatment and lived at least 6 months. So now we're taking out the transplant-related mortality, right? Still, the survival trend, no longer statistically significant, but the survival trend still in favor of standard chemo. So hard to look at that data and say that we have good evidence to support stem cell transplant as the preferred modality for this than standard chemo. Now, realize this. The options for chemo and immunotherapy over the last 15 years have absolutely exploded, as you nicely outlined up front. And so, whereas auto stem cell transplant really hasn't changed to the point where, and we just published our data here, and others, including BU, recently published their data looking at survival. And so, in rough numbers, across the various stages of AL amyloidosis, survival has tripled over the last decade compared to what it was before. And that includes at a place like Stanford, where we hardly do any stem cell transplant for this disease. So it's not because of other things. It's because the chemo's gotten better. So what all that says to me is that not only should stem cell transplant not be the goal with this disease, but as far as I'm concerned, it really should not be the upfront or kind of first thing that you're trying to get a patient to in almost anyone, where really what you're trying to do is control the light chains, to do it with the least toxicity possible, and hopefully for the longest term possible. And we now have such a host of various chemo and immunotherapy options that thankfully it's the rare patient now that we can't get somewhere between good and great control of their light chains. And if one thing's not working or is intolerable, you can move to something else. And you highlighted daratumumab, which has been an absolute game changer in this disease. It's an immunotherapy. It is typically extremely well tolerated by patients, and not for everybody, but for more than with any other treatment we've had, people will often have incredibly good responses from a light chain standpoint. So I know that's a long-winded answer, but it's and then I'm going to get to your actual question. But it is such a key thing because in many parts of the country, less so, frankly, in other parts of the world, but in this country, there's a very ingrained belief of we've got to try to get our patients to stem cell transplant, and the data just doesn't support that. Now, to answer your specific question about toxicities of therapies, thankfully, the vast majority of the agents we use for this disease don't have specific cardiac toxicity. The two things I would say are worth knowing about. One is that some of them, and in particular the IMiDs, have an increased thrombosis rate, mainly venous, but so they will generally need to be on some sort of thrombotic prophylaxis, either aspirin or systemic anticoagulation. The other one is carfilzomib. Carfilzomib is a proteasome inhibitor. It's often used if a patient has failed bortezomib, which is an earlier generation form. There is clearly a real degree of carfilzomib cardiac toxicity. I would say that from my experience, I think it's probably more worried about than actually happens, but it certainly can happen. It is not one of systolic dysfunction. It's very clear. There's very good evidence with echo studies in patients with myeloma, who are the main ones who get it, who do not develop any systolic dysfunction, but you can get some diastolic heart failure in those patients above what patients who are on placebo or alternate agents get. It can also cause some degree of increased thrombosis risk, and probably in some patient populations, increased blood pressure. So I would say carfilzomib, I would never rule out for the disease, but for cardiac amyloid, you're never going to jump right to it as your first option because of these concerns.
It's just amazing to me how different the prognosis of either type of cardiac amyloidosis is now compared to just when I was in medical school. And I think it's just something that we don't realize enough, how the advances that we have made as a field really impact the lives of the patients that we see on day to day. So I think it's just, it's really fantastic.
It's an amazing thing. And patients, they'll get the diagnosis, and the first thing, of course, they'll do typically is go online and read about it. And unfortunately, still most of what they read, they think they're going to be dead in 6 months. And save, but for the patients with the most advanced disease when they get diagnosed, thankfully that's not the case. And so it's nice to be able to quickly dispel those myths when they come into clinic, because they know that was a different era. We actually do have lots of effective treatments for you now.
It's incredible.
Yeah, it's wonderful. So Dr. Witteles, I have one last question for you. You are a person who has many hats. Not only are you a wonderful clinician, a scientist, an educator, a leader, and those are just naming a few, but I'm particularly interested in your medical education hat. On the highly successful track that brought you here today, what got you interested in graduate medical education, and how does one, especially one with such a busy career as a cardiovascular clinician scientist, become a program director of a residency program?
Okay. So I'd say first off, one of the great things about academic medicine in general is that for people who are interested in the various parts of the tripartite mission of academic medicine, that is clinical care, research, and education, that you do have the opportunity to wear multiple, including all three of those hats, should you want, and should that be of interest to you. Now, it isn't of interest to everybody. Some people really, it's the science part that really excites them, or it's the clinical part that really excites them much more so than the other parts, or the education part. And that's fine. That's great for them. But one of the nice things, if you do enjoy all three, is that is feasible. And as a clinical researcher, it is much more feasible to be able to do that along with other parts of one's career, much more so than, say, a typical bench researcher. My own view, and this is what I tell our residents or medical students if they ask me for advice, is that it's sort of silly to plot out one's exact career path of what am I going to be doing 5, 10, 15, 20 years down the line, because fate will always mock you, and you have no idea. You have no idea how your life is going to change, what opportunities are going to come up, what your interests are going to change, etc. In fact, amyloidosis was something that I only became interested at really in the last year and a half of fellowship. It had never been an interest before then. And if you had asked me going into fellowship, do you see amyloidosis being part of your career? Never would have. I was focusing on it from a research side, completely different area at the time. So you never know. So what I would say from an education standpoint is that similarly, you can't say, okay, in 5 years, I'm going to be program director, among other reasons. A lot of this is just serendipity, the opportunity coming up at the right time that aligns for you and somebody thinks of you and makes sense for you career-wise, et cetera. Rather, I would say that for any listeners who might be interested in education being a part of their career, that the thing to do when if one's joining the faculty is at the beginning, you've just got to do it. You're not likely to be given vast swaths of protected time to do it. But the good news is that not that many people really want to spend that much time doing it as part of their career. I mean, a lot of people in academic medicine, they enjoy teaching students or residents or fellows when they're on rounds or whatnot. But beyond that, that's not there are people who do, but most people don't. And if you are somebody who really does enjoy that, then go to the residency program director or the fellowship director or the clerkship director or whomever and put yourself forward as somebody who is interested in that, and just say, look, when opportunities come up to give talks, to lead physical diagnosis sessions, to X, Y, and Z, to come to a morning report as a discussant, whatever it may be, and to just be out there. And then as positions do come up, and it may be in a clerkship, it may be in a fellowship, it may be in a residency program, whatever it may be. But as positions do come up, if you're somebody who was passionate about it and who's been doing it, then they will think about you. And now you will actually get real career support for it. And that's really the pathway. Personally, for me, I really do enjoy all three of those aspects of my career. I would not want to give up any of them. And that's, again, the great thing about academic medicine is that you can't.
That's really amazing to hear, Dr. Witteles. And, I've noticed whenever I've heard a leader talk about their path, the concepts of serendipity and opportunity always come up, but I know and I can only imagine how much passion and initiative to seize those opportunities were just as essential. And, before we end, I'd like to convey a very heartfelt hellos from two of my stellar co-fellows, Grant Henderson and Alan Keong, who were, of course, your residents in the past and are definitely keeping up Stanford's good name here with their brilliance and hard work as fellows. So Alan wrote to us that Dr. Witteles is clearly someone who is incredibly invested in the residency program and cares deeply about the well-being and success of his trainees. I myself have reached out to him on several occasions for help, and each time I received advice that was prompt, personalized, comprehensive, and extremely high yield. Despite how busy he is, he always seems to prioritize his residents at the top, and I know many others who feel the same way. Grant Henderson wrote to us that Dr. Witteles is great in the CCU. Each morning rounds are like a meticulously fashioned lecture on cardiac physiology, hemodynamics, pharmacology, and clinical decision-making tailored to each patient. These lectures, of course, are not meticulously fashioned or are somehow developed on the fly. The teaching, wry wit, and storytelling that accompanies each new patient presentation makes his rounds delightful and edifying. It's hard to spend a couple of weeks rounding with him in the CCU and not wanting to become a cardiologist or at least a deeply thoughtful clinician. So Dr. Witteles, you've clearly taught and inspired generations of Stanford trainees, and we want to thank you for doing the same for us CardioNerds today.
It's exceptionally kind of you and both of you and of Grant and Alan. And I'm so happy that we've been able to send our superb Stanford residents to great programs around the country. And thanks for the invitation, the opportunity to join you today.
Well, that brings us to the end of our show, so it's time to make like an S2 and split. You can follow us on Twitter at CardioNerds. Don't forget to check out the amazing illustration that Kareen prepared for y'all at www.cardionerds.com, and please share what made your heart flutter this week. Send us a clip to cardionerds@gmail.com. If you enjoyed the show, be a nerd and spread the word. And now, a Flutter moment.
Hi, CardioNerds. I'm Lois Adamski, the Program Coordinator of the Cardiovascular Medicine Fellowship at the Cleveland Clinic. What makes my heart flutter is that each year I'm gifted with 39, soon to be increased to 42, of the most amazing people to share my day with. I started out 36 years ago being their little sister, and through the years have progressed to being mom, which is a very honorable title to hold in this program. From guiding them in the right direction to plot their way through this crazy fellowship, to sharing our life events, watching their children grow, and all of our daily laughter and shenanigans, I could not ask for a better way to spend my time when I'm not with my family. They truly make coming to work a pleasure, and I would not trade them or these years for anything. I would like to take this moment to thank those near and far for their kindness, support, and for the lifelong friendships that I have been blessed with over these years. I will treasure these memories always and look forward to making new ones over the next few years.